In 2019, a woman in California received a hospital bill after a minor procedure. Among the charges, $40 for a single aspirin tablet. Not a bottle, not a prescription, one pill. The same pill you can buy at CVS for roughly 3 cents. That's a markup of over 133,000%. And here's what makes it even stranger. The hospital didn't try to hide it. It was printed right there on an itemized bill, in plain English, as if charging 1,300 times the retail price for a common painkiller was perfectly reasonable. You've probably heard stories like this before. The $500 bag of saline, the $18 single ibuprofen, the $12 box of tissues. And every time, the reaction is the same. This has to be a scam. Someone's getting rich. Someone's getting away with highway robbery in a place where you can't say no. But here's the thing. The hospital probably didn't make a single dollar in profit from that $40 aspirin. In fact, there's a very real chance they lost money on it.
Which sounds impossible. How can you charge $40 for something that costs 3 cents and somehow not make $39.97 in profit? The math doesn't work. Except in the American healthcare system, math doesn't work the way you think it does. The numbers on your hospital bill aren't prices. They're not even close to what the hospital expects to collect. There's something else entirely. And once you understand what they actually are, the entire system starts to make sense in the most disturbing way possible. The common explanation goes like this. Hospitals charge insane prices because they can. You're sick, you're vulnerable, you can't shop around, you can't negotiate, so they exploit you. They inflate every charge to maximize profit, knowing you have no choice but to pay. It's greed. Simple, pure corporate greed. And on the surface, this makes sense.
Healthcare in America is famously expensive. Hospital corporations are massive, many of them for-profit. And when you're wheeled into an emergency room unconscious, you're not exactly in a position to ask for a price list. The evidence seems overwhelming. The average cost of a 3-day hospital stay in the United States is around $30,000. A broken leg can cost $7,000. An appendectomy, $33,000. In countries with universal healthcare, those same procedures cost a fraction of that amount. A broken leg in Spain costs around $2,000. An appendectomy in the UK runs about £3,000, fully covered by the NHS. So clearly, American hospitals are charging more because they're greedy, right? Except here's what doesn't add up. Despite these astronomical prices, nearly a third of American hospitals operate at a loss. According to a 2022 report from Kaufman Hall, over 50% of hospitals had negative operating margins. They're not swimming in cash. Many rural hospitals are shutting down entirely. If hospitals were simply jacking up prices and pocketing the difference, they'd all be wildly profitable. But they're not. In fact, when you look at hospital profit margins, they're shockingly thin. For-profit hospital chains like HCA Healthcare report net margins around 5 to 7%, not 50%, not even 20%, single digits. Compare that to Apple's profit margin, which hovers around 26%, or pharmaceutical companies, which often exceed 20%. So if hospitals aren't making a fortune on that $40 aspirin, where is the money actually going? And more importantly, why charge $40 in the first place if you're not keeping it? That's the question everyone gets wrong, because the $40 aspirin isn't about the aspirin. It never was. It's about something far stranger, far more broken, and completely invisible to the patient staring at the bill. The real answer requires going back to a single decision made decades ago that twisted the entire pricing system into something almost unrecognizable. To understand why hospitals charge the way they do, you have to go back to 1965. That's the year Medicare was created. Before Medicare, hospitals operated like most businesses. They set prices, patients paid those prices. If you couldn't afford it, you worked out a payment plan, or you didn't get care. It was brutal, but the pricing model was straightforward. A service had a cost, and that cost was listed. When Medicare launched, the government needed a way to pay hospitals for treating elderly patients. But they didn't want to just pay whatever hospitals charged. That would create an incentive to overcharge the government. So Medicare decided to do something different. They told hospitals, send us your bills, and we'll pay a percentage of your usual and customary charges. Seems reasonable. Except this created a perverse incentive that broke everything. Here's what happened. If Medicare was going to pay a percentage of what you charged, the logical move was to raise what you charged. If you billed $100 for a procedure and Medicare paid 80%, you'd get $80. But if you billed $200 for the same procedure, you'd get $160. So hospitals did exactly that. They inflated their Chargemaster prices, the official list prices for every service and item, to astronomical levels, knowing Medicare would only pay a fraction. The Chargemaster is a massive document, sometimes containing tens of thousands of line items, listing the official price for everything a hospital provides. A single dose of aspirin, a Band-Aid, an MRI, a heart surgery. And because these prices were being used as the starting point for negotiations with Medicare, Medicaid, and private insurers, they bore no relationship to actual costs. By the 1980s, this had spiraled completely out of control. Hospitals weren't just padding prices a little, they were listing charges 5, 10, even 20 times higher than their actual costs. A bag of saline that cost a hospital $1 might be listed at $79. Not because anyone was expected to pay $79, but because insurance companies and government programs had started negotiating discounts off the Chargemaster price. If Blue Cross negotiated a 60% discount and you wanted to still collect $30 for that saline bag, you had to list it at $75. If Medicare's reimbursement formula used your charges as a baseline, you inflated them even more. Every player in the system understood this. Insurers knew the Chargemaster prices were fake, Medicare knew, Medicaid knew, hospitals knew. Everyone was playing a game where the listed price meant absolutely nothing. It was a starting point for a negotiation, not an actual price. Except for one group of people who didn't know the game. Patients, specifically uninsured patients. Because here's the cruel twist. While insurance companies and government programs negotiated discounts of 50, 60, sometimes 70% off the Chargemaster price, uninsured patients were often billed the full amount, the fake price, the number that was never meant to be paid by anyone. And that decision, made over 50 years ago to create a fake pricing system for negotiation purposes, is the reason you're still seeing $40 aspirin tablets on hospital bills today. But the origin story is only half of it. The real genius, or the real trick, is how this system evolved into something even more complicated. Because once you understand what hospitals are actually charging for, the $40 aspirin starts to make a kind of twisted sense. Here's what most people don't realize. A hospital doesn't have one price for a service. It has dozens, sometimes hundreds. Every insurance company negotiates its own rates. Medicare sets its own reimbursement schedules. Medicaid has different rates, and those rates can vary wildly. For the exact same procedure, a hospital might collect $3,000 from one insurer, $4,500 from another, $2,200 from Medicare, and $800 from Medicaid. But all of these negotiations are based on a discount from the Chargemaster price. So the Chargemaster has to be high enough to ensure that even after the deepest discount, the hospital still covers its costs and keeps the lights on. Let's use a real example. Suppose it costs a hospital $2,000 in real expenses to perform a knee surgery. Staff time, equipment, facility overhead, the works. $2,000. That's the actual cost. Now, Medicare might reimburse the hospital $2,200 for that surgery based on their fee schedule. That gives the hospital a $200 margin. Fine. But Blue Cross Blue Shield negotiates a 50% discount off the Chargemaster price. If you want to collect at least $2,000 from Blue Cross, you need to set the Chargemaster price at $4,000. But United Healthcare negotiated a 60% discount. So to collect $2,000 from them, the Chargemaster price has to be $5,000. You see the problem. The hospital has to set the Chargemaster price high enough to accommodate the deepest discount from the worst-paying insurer. And since each insurer negotiates different rates, the only safe move is to make the Chargemaster price absurdly, comically high. So the knee surgery gets listed at $10,000, not because anyone is expected to pay $10,000, but because it ensures that no matter which insurance company pays, the hospital collects enough to break even.
Now apply this logic to that $40 aspirin. The aspirin itself costs the hospital maybe 5 cents when purchased in bulk. But it's not just the pill, it's the nurse's time to retrieve it, the pharmacist who verified the order, the electronic health record system that logged it, the compliance protocols, the inventory tracking, the liability insurance in case something goes wrong. When you add up all those indirect costs, labor, systems, overhead, that single aspirin might carry a true cost to the hospital of maybe $2 or $3 when you allocate everything properly. But remember, insurance companies don't pay the Chargemaster price. They pay a fraction. If the average insurer pays 30% of the Chargemaster rate and the hospital needs to collect $3, they have to list the aspirin at $10 just to break even. Except they don't list it at 10. They list it at 40. Why? Because Medicare might only reimburse 50 cents for medications under certain diagnosis codes. Medicaid might pay even less, and some insurers have negotiated discounts of 70 or 80%. So to make sure they collect enough across all payers, the Chargemaster price gets pushed into the stratosphere. Here's where it gets really interesting. Hospitals also use these inflated prices to subsidize other parts of their operation that lose money. Emergency rooms, for example, are required by law to treat everyone who walks in, regardless of ability to pay. A huge percentage of ER patients are uninsured or underinsured. Hospitals lose billions annually on uncompensated emergency care. So where does that money come from? It comes from overcharging everywhere else. The $40 aspirin isn't just covering the cost of the aspirin. It's covering the cost of the uninsured patient who came in last night with a heart attack and will never pay a dime. It's covering the Medicaid patient whose reimbursement doesn't come close to the actual cost of care. It's covering the hospital's compliance with federal regulations that require certain unprofitable services to remain available. This is called cost shifting, and it's the invisible engine behind almost every confusing hospital charge. Hospitals can't charge different prices to different patients for the same item. That's illegal. So instead, they charge everyone the same fictional price, knowing that every payer will negotiate it down to a different number. The Chargemaster becomes a kind of universal anchor price from which all discounts flow. And because the system is so opaque, most patients never see the real transaction. Your insurance company gets billed $40 for the aspirin, pays $12, and you see a $3 copay. You never know the original charge was fake. You never know your insurer negotiated a 70% discount. You just know you paid $3 and your plan covered the rest. But if you're uninsured, you get the bill for $40, the full Chargemaster rate, the price that was never designed to be paid. That's the machine, a pricing system built on fiction, held together by negotiation and subsidized by cost shifting. It's not designed to be logical. It's designed to extract maximum revenue from insurers and government programs while maintaining the legal appearance of uniform pricing. And here's the kicker. Everyone in the system knows it's absurd. Hospital administrators know, insurance executives know, politicians know, but no one has an incentive to change it. Hospitals need the inflated Chargemaster prices to negotiate with insurers. Insurers need the inflated prices to show their members how much money they saved through negotiation. And the whole house of cards is propped up by patients who either have insurance and never see the real numbers, or don't have insurance and get crushed by bills they were never supposed to pay. It's not a bug. It's the entire design.
Let's look at how this plays out in the real world with real numbers. In 2013, journalist Stephen Breaux published a landmark investigation in Time magazine called Bitter Pill: Why Medical Bills Are Killing Us. He examined hospital bills from across the country and found the same pattern everywhere. One hospital charged $1.50 for a single generic acetaminophen tablet, the same pill that costs about 2 cents at Walmart. A hospital in California charged $7 for a single alcohol swab, the kind you can buy in a box of 200 for $3. MD Anderson Cancer Center in Houston charged $283 for a chest x-ray that Medicare reimburses at $20. Stanford Hospital in Connecticut charged $99 for a trauma activation fee, essentially the cost of having an ER team on standby, even for patients who walked in with minor injuries. It's not just a few bad actors. This is every hospital.
Researchers at Princeton analyzed hospital pricing data and found that Chargemaster prices are typically 2.5 to 10 times higher than Medicare reimbursement rates. Some items are marked up even more. Implantable medical devices can be charged at 300 to 500% of the hospital's acquisition cost. A study published in Health Affairs examined the cost of knee and hip replacement surgeries at hospitals across the U.S. For the exact same procedure, Chargemaster prices range from $11,000 to over $125,000. Not because the surgery was different, not because one hospital used better equipment, simply because each hospital set their Chargemaster price based on their unique mix of payer contracts. And here's the evidence that proves cost shifting is real. Hospitals in areas with higher uninsured populations have higher Chargemaster prices. A 2015 study in the Journal of Health Economics found that for every 10% increase in uninsured patients, hospitals raised their Chargemaster prices by an average of 8%. Why? Because they needed to extract more from insured patients to cover the losses from uninsured ones. This even happens within the same hospital chain. HDA Healthcare, the largest for-profit hospital operator in America, owns over 180 hospitals. Their facilities in states that didn't expand Medicaid, meaning more uninsured patients, have significantly higher Chargemaster prices than their hospitals in expansion states. Same company, same standards, same equipment. Different prices because the local payer mix is different. The pricing insanity extends to every corner of the hospital. A study from Johns Hopkins examined the cost of common lab tests. A basic metabolic panel, a routine blood test, had Chargemaster prices ranging from $14 to over $1,400 depending on the hospital. The actual cost to perform the test? About $6 in reagents and labor. And it's not just line items. Entire categories of hospital services operate at a loss, subsidized by overcharging elsewhere. According to the American Hospital Association, hospitals lose an average of $6.2 billion annually on Medicare patients and $21 billion on Medicaid patients because reimbursement rates don't cover costs. Where does that $27 billion shortfall get made up? Private insurance patients. Commercially insured patients subsidize government-insured and uninsured patients through higher prices. A Rand Corporation study found that private insurers pay hospitals an average of 241% of what Medicare pays for the same services. You read that right. If Medicare pays a hospital $100 for a procedure, the private insurer pays $241. Same procedure. Same outcome, but the hospital has to charge more to compensate for the money they lose on Medicare patients. This is the evidence wall. It's not just one hospital. It's not just one type of charge. It's a systemic pattern that shows up in every dataset, every investigation, every independent study. The Chargemaster prices are disconnected from reality because they were never meant to reflect reality. They're tools in a negotiation game where the only people who don't know the rules are the patients. But here's the deeper layer that changes everything. This entire system only works because most patients never actually pay the Chargemaster price. If you have insurance, you're shielded from it. The insurer negotiates the real price, and you pay a copay or coinsurance based on the contracted rate, not the fake list price. You see the inflated number on an explanation of benefits form, but it doesn't hit your wallet. And if you're uninsured and you get hit with the full Chargemaster price, here's what hospitals don't advertise. Those bills are almost always negotiable. Under pressure from regulators and bad publicity, most hospitals now have financial assistance programs. If you're uninsured and your income is below a certain threshold, often 200 to 400% of the federal poverty level, the hospital is legally required to offer you a discount or even completely forgive the bill. This is called charity care, and it's a condition of tax-exempt status for nonprofit hospitals. In 2020, nonprofit hospitals provided an estimated $28 billion in charity care. So in many cases, that $40 aspirin bill, if you're uninsured and you ask for help, you might end up paying nothing. Or the hospital might offer you the Medicare rate, which could drop the bill by 70%. But here's the twist. Hospitals don't tell you this up front. They send you the full bill. They wait to see if you'll pay it. Many people, terrified of debt collectors and damage to their credit, scrape together money and pay bills they could have negotiated down to almost nothing. According to a 2022 report from the Kaiser Family Foundation, only about 15% of eligible patients actually apply for hospital financial assistance. The other 85% either don't know it exists or don't know how to navigate the process. This creates a bizarre secondary market. Hospital bills that go unpaid get sold to collections agencies for pennies on the dollar. A $10,000 hospital bill might get sold to a debt buyer for $500. The debt buyer then pursues the patient for the full amount, knowing that even if they settle for $2,000, they've made a profit. The hospital writes off the loss. The patient's credit gets wrecked, the debt buyer makes money. And the whole thing could have been avoided if the patient had known to ask for a discount in the first place. But there's an even stranger layer. Some hospitals have been caught actively hiding their financial assistance programs. A 2019 investigation by MLK 50 and ProPublica found that Methodist Le Bonheur Healthcare in Memphis was suing thousands of low-income patients for unpaid bills, many of whom would have qualified for charity care, while simultaneously receiving tens of millions in tax breaks as a nonprofit. They were legally required to offer help, but they made the application process so difficult and advertised it so poorly that most patients never knew it was an option. This isn't rare. A study published in the Journal of General Internal Medicine found that fewer than 10% of hospital websites prominently displayed information about financial assistance. Many buried it in dense legal documents or required patients to specifically ask for it. So the $40 aspirin exists in this strange quantum state. The hospital charges it knowing almost no one will pay it. Insurance companies negotiate it down to almost nothing. Uninsured patients who ask for help get it reduced or forgiven. But uninsured patients who don't know to ask, often the most vulnerable, least educated, least financially literate, get stuck with the full bill. It's a system that punishes lack of knowledge. And that might be the most disgusting part of all. Every time you interact with the American healthcare system, this machine is working on you. When you see your explanation of benefits after a doctor's visit, and it says the provider billed $450, but your insurer negotiated it down to $120, that $450 was never real. It's the Chargemaster price, the anchor. Your insurer wants you to see that number so you feel grateful for the discount they negotiated on your behalf. But you're not saving $330. That was never the actual price. When you walk into an emergency room and later receive a bill with dozens of separate charges, a facility fee, a physician fee, a triage fee, separate charges for every bandage and medication, that's cost shifting in action. The hospital is breaking down every component to maximize revenue extraction from every possible source. And here's what really matters. This system is why healthcare is unaffordable even if you have insurance. Because private insurers have to pay 2.4 times what Medicare pays to subsidize the system, and because hospitals keep raising Chargemaster prices to maintain negotiating leverage, the contracted rates keep going up. which means insurance premiums keep going up, which means your deductible keeps going up. You're not just paying for your own care, you're paying for the uninsured patient in the next bed. You're paying for the Medicaid shortfall. You're paying for the hospital's legal obligation to run an unprofitable emergency department. You're paying for a pricing system that requires every transaction to be a negotiation because there's no such thing as a real price. If you've ever been hit with a surprise medical bill, an out-of-network charge you didn't expect, a service your insurance decided not to cover, a bill for a doctor you never met who happened to be in the operating room, that's the system breaking down. Because the negotiated rates only apply to in-network providers, and if anyone in the chain of your care is out of network, you get billed the full Chargemaster price. Until recently, this was completely legal. You could go to an in-network hospital, receive care from an out-of-network anesthesiologist without knowing it, and get a bill for $20,000. The No Surprises Act, which went into effect in 2022, banned some of these practices, but loopholes remain. The point is, you can do everything right, have good insurance, go to the right hospital, and still get financially destroyed because the pricing system is fundamentally broken. And the reason it's broken is because it was never designed to serve patients. It was designed to facilitate negotiations between hospitals and insurance companies, with patients as collateral damage. So why does a hospital charge $40 for one aspirin? Because in a system where prices are fiction and every transaction is a negotiation, the only way to stay solvent is to charge amounts so absurdly high that even after the deepest discount, you still collect enough to keep the lights on. The $40 aspirin isn't about the aspirin. It never was. It's about a 50-year-old billing scheme that turned healthcare pricing into a game where everyone lies about the numbers, everyone knows everyone is lying, and the only people who get hurt are the ones who don't know they're playing a game. The hospital doesn't expect you to pay $40. The insurance company doesn't pay $40. Medicare definitely doesn't pay $40. But the $40 price has to exist so that when all the discounts, negotiations, and cost shifting shake out, the hospital collects the $3 it actually needs. And the truth is disgusting because it didn't have to be this way. Other countries have healthcare systems where prices are transparent, regulated, and tied to actual costs. But in America, we built a system where the price you see is never the price anyone pays, and the complexity itself has become the product. Hospitals benefit from the confusion. Insurers benefit from the opacity. The only ones who don't benefit are patients, the people the system was supposedly built to serve. That $40 aspirin is a perfect symbol of American healthcare, wildly overpriced, completely disconnected from value, and designed to extract maximum revenue from a captive population that has no choice but to pay. And the worst part? It's working exactly as intended.